Hello, everyone. I'm Dr. Ray Townsend from the University of Pennsylvania in Philadelphia, a nephrologist and someone who has been working in the field of renal denervation since 2011, and glad to be joining you today.
My name is Roland Schmieder. I'm a professor of medicine working at the University Hospital in Erlangen in Germany. I'm involved in the business of renal denervation for more than 10 years, starting with Simplicity 2 and onwards. It was an interesting, very exciting journey, and I'm glad to hear more about during this conversation.
So, Roland, good to see you again. Let's start off with a bit of an update on what's the latest in renal denervation. Maybe you could share your experience from Germany or from the European side, and I'll add from the US side.
Very interesting this second half of the year when we had the meeting at the American Heart Association, the meeting at the TCT, and in both meetings, new data have been presented, reconfirming, and I want really to underline that, reconfirming the efficacy that renal denervation indeed lowers blood pressure. And I found it also exciting that at least in Europe, we have a consensus conference, and and some key issues of the consensus conference by the European Society of Cardiology and by the Society of the Invasive Cardiologists have been released at the European Society of Cardiology in August. I think these are new developments which helps us to transfer renal denervation from clinical science now to clinical practice. I do not know what was the most impressive results you have heard during this fall.
And I'll just add to that it's been an impressive thing that both an ultrasound approach as well as a radio frequency energy approach have shown very similar reductions in both office as well as 24-hour blood pressure reduction, which gives us some confidence that the whole concept of renal denervation seems to be a reliable one for blood pressure management.
You know, what I found exciting is that the average decrease, and I usually refer to office blood pressure changes because when I treat my patients, they want to know how much does renal denervation lower blood pressure. And I think office blood pressure is the measurement which a patient understands. And at the end, it also translates to prognosis. And I think that's another issue we need to discuss about is, let's say, roughly 10 milliliter mercury fall on average by renal denervation, is this associated with improved prognosis? What is your feeling on that? Because we don't have large randomized trials with 50,000 people.
Well, Roland, we're getting there. So we have about 20,000 people to date that have been treated with renal denervation, at least from the radio frequency energy side. And even though in the US it's not approved, I don't know of any drug for hypertension that has had so much pre-approval experience with repeated documentations of efficacy. Our problem, as you know, and as the audience knows, is occasionally our control group has a better than expected response, and that has just made it a little bit more challenging and raised the bar a little bit. But the office blood pressure reductions are consistent, and even in the most recent on-med expansion trial in Medtronic, the office blood pressures were significantly lower at the 6-month primary endpoint in the active arm of the renal denervation study. So I think that that's a useful way to present it. And for clinicians in general, since we simply multiply the millimeters of blood pressure reduction, systolic blood pressure reduction, times 2, we get a likelihood of the amount of cardiovascular endpoints reduced. So if you have a 10 millimeter office blood pressure reduction, you can expect over the coming years to see about a 20% reduction in cardiovascular endpoints.
Ray, I think I usually referred to the Global Simplicity Registry with respect to prognosis, because there we have long-term data, we have captured adverse effects, and together with some colleagues, I did a project in estimating the benefit of a reduction by renal denervation. And when we have an average in the Global Simplicity Registry, a decrease by 14.7%, if you translate that based on pharmacological huge meta-analysis into prognostic data, we can expect a decrease around roughly, let's say, 30% of MACE, of major cardiovascular events. And I think this is really quite striking. Also in absolute terms, in these high-risk patients, we found a reduction of approximately 4% in absolute risk reduction, which is quite huge in my opinion. Well, it is at least an idea what we can expect from using now renal denervation in clinical practice, you know. I think, Gray, another issue which is important we should really discuss briefly is, usually I forget it, safety. I think usually because actually, you know, it's not a real problem, but I think maybe the audience wants to know what kind of data do we have with respect to safety. And you did a very nice meta-analysis, I remember very well.
Yes, and it is significant that two nephrologists talking to one another are all interested about the blood pressure and the cardiovascular endpoints. And so when we look at safety, though, our regulatory agencies are often looking at the kidney, both the kidney function and the kidney circulation for safety. And the good news about this aspect is that so far, kidney function has not